So we're in the midst of an economic crisis, and epilepsy is a challenging and sometimes expensive disease to investigate and to treat. As a nod to those clients that may have a limited budget, this lecture is going to deal with how to manage and diagnose epilepsy where funds are limited. Dealing with a diagnosis of epilepsy in a pet is challenging for any caregiver, but it's even more challenging when you're having a low income, because this chronic diagnosis requires a lifetime of medication and testing. And the aim of this lecture is to give information on the most economical way of managing these pets. I originally wrote it for Street Vet, which is a charity offering veterinary care to the homeless. And much of what I'm going to say applies in that context, but I've also tried to make it applicable for any general practitioner that is managing epilepsy in where there is a budget or even a low level of insurance. So what we're going to talk about is, first of all, whether or not we're actually dealing with epilepsy, because that's quite important. There are many paroxysmal events which look like seizures but are not seizures. We're next going to talk about the neurological examination, what therapy is most economical to start, and the context of that if the animal has more serious disease. The client education and support, and reviewing and adjusting. So first of all, is it a seizure? This border terrier here is in the middle of a paroxysmal event, and it certainly looks seizure-like. The dog has got tremors and movements that it doesn't appear to have control over. We can see some vomit in front of the dog. Sorry if that's upsetting, but that's a reality of this particular condition, that they often have gastrointestinal upset at the same time. But is it a seizure? Actually, what this is paroxysmal dyskinesia, which is a movement disorder, and it certainly looks seizure-like. The dog has poor control over its movements. It has spontaneous abnormal movements, and it has this marked flexion of limbs. And we can see the dog now is making its way over to this box, which it gets into. The fact it does this, it gets to an area of security, is a very strong indication that this is not a seizure, because this dog is conscious and aware whilst this event is taking place. And this, as I said before, is a paroxysmal dyskinesia and not a seizure. So it is important to rule out other paroxysmal events, and for that, the mobile phone has really been extremely useful. So in all circumstances, try to get a video of the event to look at what it actually is. This flowchart is really sort of looking at the cause of the seizures, which I always divide into things going wrong with the brain and things going wrong with the blood going to the brain. And the technical expression for that is extracranial causes, or more commonly reactive causes. And I show this flow diagram really to show the diagnostic workup of a patient with seizures. And so things going wrong with the blood, they could have too many toxins in the blood, or and these could be produced by internal organs, so having liver failure, hepatic encephalopathy or a liver shunt, renal failure, or other rare metabolic diseases. This stands for L2-hydroxyglutaric aciduria. Or it could be that the toxins have been taken in externally, and for presentation of seizures, these are usually recreational drugs, drugs of abuse, drugs which are used to that are toxic and used to kill parasites, and toxins produced by fungi. And then we have too little of things that are vital to the brain, so glucose, electrolytes, and fatty acids. So when we look at those all can be, not all, but most of them can be ruled out with hematology and serum biochemistry, so what we call blood work. In America, they'll call it a CBC and chemistry, I think. The next sort of test which you can do would be to look for urine toxicology. That can be quite expensive. I'm going to show you a hack for that. But those are all tested from a urine sample. And then we could do specific genetic testing for some of the inherited disease. So that depends on the breed. Always worth a Google to the breed. So L2-hydroxyglutaric aciduria is found in Staffordshire Bull Terriers. And occasionally in other breeds like Westies. And Laforet's disease is found in older dogs. It could potentially be any breed or a crossbreed, but it's most commonly associated with miniature wirehaired Dachshunds, Beagles, and Basset Hounds, and Griffon Bruxellois more rarely. And then our next workup is for the diseases that cause damage to the brain, which we will refer to as structural epilepsy. So they've done structural damage to the brain. And these are ruled out by neurological exam, which we're going to talk about is your most important test, and or an MRI scan. Well, not or, in addition, an MRI scan may be used to support your neurological examination. When the structure of the brain is normal, at least normal to look at from an MRI point of view and even under the microscope, then we refer to this as idiopathic epilepsy, which is not a term used to describe we don't know the cause of. It's a term used to describe that we recognize this as a syndrome, but that the brain is structurally normal. And we divide those into unknown causes and breed-related causes. There's also a genetic cause of this, but the genes for this are complex and have not yet been discovered. There are some genes that have been discovered, but these will result in actual structural changes to the brain, and so are not really counted as idiopathic epilepsy. Breeds that commonly get epilepsy are the collies, border collie, Australian shepherd, and the Labradors, and many other breeds. In fact, it's very unusual to find a purebred dog that is not predisposed to epilepsy. I'm thinking West Highland White Terrier is not predisposed to inherited epilepsy. So I said I promised you a drug of abuse hack, and that is to have these urine test kits. There's many different ones available. I'm not promoting this one. It's just that one that had a picture. You can purchase them online and in pharmacies, and they're used for testing humans for drug of abuse. But they can be used for dogs as a quick, should we say, bedside or cage side test, especially as these dogs that have been given or ingested these drugs will be presenting a status epilepticus. We want to find out whether or not they have these drugs in their system very quickly. There's a question of MRI, which I've dealt with in another lecture, but I'm sort of going to rehash here. We need to have a clear understanding of what MRI is. It's often touted as a gold standard, but it really isn't, because a gold standard diagnostic test would tell us about why the epilepsy was occurring. So it might be functional, or it might reveal the chemicals that are abnormal. It might show the nerves that were abnormal, the nerve cell activity, or it would provide information about whether it was inherited. No, it doesn't do any of these things. It is structural imaging. And in fact, if we wanted to find out more about what the cause of epilepsy, we'd have to do all of these tests, which are sometimes done in humans. So really, when we do an MRI scan, we are just ruling out structural abnormalities that can be seen with a resolution of a machine that is able to get down to about 1 millimeter. Well, you may think that 1 millimeter is very, very small, and of course it is, but you can get hundreds of neurons in a millimeter. And some diseases, I've said before, be much, much cheaper to diagnose with a DNA test. And I mentioned this disease before, L2-hydroxyglutaric aciduria. This is what it looks like on an MRI scan. It's quite characteristic for an MRI scan. You see this very high signal through the grey matter, not specific for this disease, but this would be the first disease that you thought of when you saw this. But honestly, it would be much easier to diagnose with a DNA test, which is less than $100. I've also mentioned this before, but it's worth re-saying here that we have 3 tiers of confidence in our diagnosis of idiopathic epilepsy. That is to say, epilepsy where the structure of the brain is normal. Tier 1, Tier 2, Tier 3. Tier 2 is where it's supported by a brain MRI, and Tier 3 is really more aspirational in veterinary medicine, because we need to have had an EEG, which is really not very commonly available. Tier 1 is having 2 unprovoked epileptic seizures at least 24 hours apart, having an age of onset. This is typical for idiopathic epilepsy, so that's between 6 months and 6 years, and having a normal neurological examination in between fits, and having normal blood work. And so really, Tier 1 is absolutely acceptable, especially if there is more than 6-month history of seizures. So although one might argue that an MRI scan is quite useful to prove as much as possible that the structure of the brain is normal, it is not essential, and we must never underestimate the value of doing a neurological examination. So what I'm basically saying is, if you saw a dog and you did a neurological examination in January and found it was normal, and then saw the dog back in June and it continued to have seizures and its neurological examination was normal, then there is an incredible, and it was between 6 months and 6 years, and perhaps was a specific breed that was known to get epilepsy, then there is an extremely high likelihood that it does have idiopathic epilepsy, and this is enough confidence for making a diagnosis. We need to manage our clients' expectations with MRI, otherwise they can spend a huge amount of money, and that might not actually be that client's best spend. So in idiopathic epilepsy, there's no structural abnormalities of the brain, meaning the diagnosis is a rule out, and an MRI doesn't tell me what drug to use, doesn't give me a prognosis or whether the dog will respond to that drug. And also importantly, because I have these cases referred to me, if the dog previously had a normal MRI and a diagnosis of idiopathic epilepsy, then repeating the MRI is unlikely to be useful. And this is because I often get referrals of people saying the dog's seizures aren't controlled. I'd like to re-refer for an MRI. That's not going to tell you what drug to use or help the animal's epilepsy. The reason why the dog's epilepsy is hard to control is because epilepsy is often hard to control. And it would be actually better for that caregiver to spend the money having a consultation with an expert, which will be a fraction of the cost, a 100th of the cost, rather than spending the money on an MRI scan telling them exactly what they knew already. If the client has limited funds or insurance, we have in the UK some insurance policies that will just cover the cost of an MRI scan. Well, you have to bear in mind that the cost of that MRI scan in the UK is about equivalent to managing that dog for 1 to 4 years. So you have to discuss with the client, even if they are insured, whether that is the best spend of their insurance pot. Sometimes it might be, other times it will not be. So if the neurological examination is normal, and I stress again, this should be repeated at different time point, then management is arguably actually a better investment for that caregiver. However, there are some caregivers who are so anxious about their pet and the thought that they could have a brain tumour. And that anxiety should not be underestimated. That actually obtaining an MRI scan may be the best choice for them, because they can move on through that, and that will help them deal with the fact that their animal has been diagnosed with epilepsy. And also that, you don't have to hurry into this decision if the neurological examination is normal. It's perfectly acceptable to decide not to do an MRI immediately, and then perhaps review that decision. For example, if you find that the epilepsy is not controlling how you would expect, bearing in mind that sometimes seizures can be very difficult to control. But if the neurological examination is abnormal, then, and they have enough money in their insurance pot or limited funds to do an MRI, then perhaps that is the best spend, because if the animal has a disease with a poor prognosis, such as a brain tumour, then maybe it's better to know that sooner rather than later and before you've spent a lot of money. So, as I've said before, neurological examination is our single most important test, and fortunately, it's pretty cheap. And this image here shows you the first part of a neurological exam, which is really the thing that you need to do for evaluating for forebrain disease. The back part of this sheet is the spinal reflexes, which are used for localizing a spinal lesion, so not as applicable. So your aim is, are there neurological deficits? And to repeat it. So if the animal's had a seizure, low budget case, we would have the dog have a neurological examination maybe 2 weeks later, or maybe 4 weeks after that, much cheaper than an MRI scan. We want to know if there are neurological deficits, is it consistent with forebrain disease? Why is that important? Well, seizures come from the forebrain. So if an animal is having seizures and they also have evidence of a focal forebrain disease, then it's much more likely that you are dealing with a focal forebrain problem, such as a brain tumour. Alternatively, you may have found things that are consistent with a multifocal process. For example, you may have found signs that suggest vestibular disease. Well, that's a whole different kettle of fish, as they say, because that would suggest that there is something causing disease that can cause seizures and something that's causing disease that can affect the balance. And that a multifocal process is usually inflammatory, either infectious inflammatory or non-infectious inflammatory. So that would perhaps prompt a different investigation, looking for infectious causes perhaps, or prompting for recommending CSF analysis if an MRI scan couldn't be afforded, bearing in mind the risks of that. So I've put that, remember the 4x4 brain signs. What do I mean by that? So 4 brain signs with 4 brain signs, 4x4. The first of those is circling, and they will always circle towards the problem. And forebrain circling is characterized by quite a coordinated ability to do the circling. There's no signs of leaning, head tilt, or poor balance. They will have proprioceptive deficits or paresis that are opposite to the side of the problem. And this is because of decussation. So the motor tracts decussate, which means cross over to the other side. It will have visual deficits, a central blindness, and this will be most severe opposite to the side of the problem, again due to the decussation. When I say most severe, there is a little bit of that you may detect that there may be a menace response on the medial side of the opposite side, but to be perfectly honest, that is quite subtle, and most people will not be able to detect that, but just because of the difficulty of stimulating that side, and it will also be difficult to see that animal has some vision in the central blind side. So to all intents and purposes, the animal has a complete loss of vision opposite to the side of the problem, and they have vision preserved ipsilateral to the side of the problem. And again, this is also because the optic visual pathways decussate. And importantly, they will have a normal papillary light reflex, and that is because the papillary light reflex is a brainstem reflex. So when they have forebrain disease, that is not affected if they are blind. And they are obtunded, so reduced mental status, depressed, however you want to describe it, or their behavior has changed. So those are the 4 forebrain signs: circling, proprioceptive deficits, and visual deficits, which are on the same side as each other and opposite side to the problem, and altered mental status, obtunded, different behavior. Why is it important to know whether they have forebrain disease? And perhaps more useful to obtain an MRI scan. So this is a dog which had a pretty long history of epilepsy, 1 year history of epilepsy, and we can see the cystic lesion here. And here, this is probably a cystic meningioma. It's a breed that is typical for getting idiopathic epilepsy, but it's a much older dog, so that already increases the risk factor. And it had some unusual seizures. They were focal seizures with secondary generalization. So it meant it started as a little focal seizure, for example, in the head, and then spread to a generalized seizure. It also had some behavioral changes. So there was our Forebrain, one of our Forebrain sides, and it was unusually sedated on anti-epilepsy drugs. Other than that, the caregivers wanted to maximize her quality of life, so we altered the medication. We gave her a low dose of prednisolone. So prednisolone will reduce the edema associated with the tumor, reduce its irritation, reduced her doses of anti-epilepsy drugs because she was very sedated on them, gave her a drug called levetiracetam, which is licensed for human epilepsy for focal seizures. So that was going to hopefully stop the seizure starting. And we gave her a drug called propentafilene, which is licensed for senility, but has some mild anticonvulsant activity. And her demeanor improved, and she had a good quality of life for 3 months before they decided eventually to euthanize her. So one of the most common questions I'm asked is when to start anti-epilepsy drugs. And I put down here this very busy slide, which is the consensus, which I'm sure if you're a neurology resident, then you should be making good notes from this. But for everybody else, we want the simple summary. And so that is basically 2 or more seizures within 6 months. And that may surprise some of you. Some of you may be going for many more seizures than that. And actually, when you poll veterinary neurologists, they can be quite variable on that. But one thing that's a definite is that they generally will start epilepsy therapy when the seizures are more frequent than every 3 months. The 6 months can sometimes be debatable. But our consensus, it should be said, is 2 or more seizures within 6 months. Having very bad seizures. So if you have a very prolonged seizure or a very, very bad post-ictal period or status epilepticus, or if you have structural brain disease like that border collie with a brain tumor, which has basically a very high risk of repeat seizures, you'd be very confident that the animal will continue to have seizures. So don't bother waiting for the second seizure in that instance. Now, some of you may be thinking, oh, no, I wouldn't be starting anti-seizure therapy then. Some of you may actually be caregivers of an epileptic pet. You may be thinking, no, I'm going to wait until it's really bad because the medication is worse than the seizures. Is it? There is a huge risk to delaying treatment. And there have been many studies that have shown that there is more chance of successful long-term seizure management when the anti-epilepsy drug is started early, especially in dogs with a lot of seizures. And in fact, if the animal has had more than 10 seizures during that first 6 months, then the prognosis for control of seizures is really poor. Now, that was for Australian Shepherds, which do have a poor prognosis for management of idiopathic epilepsy. But I think that I can say anecdotally and from experience that this is the situation. So if you are currently of the opinion that you'll wait until the last possible few weeks between seizures before starting therapy, then you really need to think again. And certainly, caregivers can have the perception that it's not a good idea for my dog and will be very resistant to that. And I think we have to tell people that actually that you may have the perception that medication is worse than the seizures, but the seizures are the thing that is life-threatening and can definitely be worse than the medication and more disruptive than the medication. And after all, you can always reduce the medication or even stop the medication if it's appropriate, but you can't do the same with the epilepsy if you really want to. There is also for many breeds, a poor response to the anti-epilepsy drugs if they're male or if they have cluster seizures, especially the cluster seizures. This can vary with breed, but if an animal starts with cluster seizures, for me, they are going to be going on anti-epilepsy therapy, or at least it's going to be extremely strongly recommended. So, what about choosing the medications? Well, this is UK. You may be listening from a different country, in which case, welcome and thank you for the trust in listening to this lecture. But these are the licensed epilepsy costs, drug costs in the UK comparison. It may be different in your country. And these are the drugs that are licensed for management of epilepsy in dogs in the UK, but also as a monotherapy, although bromide is typically used as an add-on. So, and is licensed as an add-on. So you can see here, by far the cheapest cost per month is, although still considerable, and depending on how you source the drugs, is phenobarbital. And I've put a rough scale here, but there are cheaper ways of obtaining these drugs, and it depends on your practice and whether there's an online, for example, using a pharmacy prescription can be a cheaper way of obtaining them if the vet will be able to write such a prescription. So phenobarbital is by far the cheapest, and then we have bromide, and then we have epitoin, which is marketed as Pexium. But you also have to consider the cost of monitoring, and you need to take blood samples to measure phenobarbital and bromide, and you don't have to with Pexium. You also have to monitor hematology and serum biochemistry, and that has blood sampling and consultation costs. So that may mean that a drug like Pexium becomes more economical for some clients, and it's worth looking at overall all of these costs. But we also choose medication based on effectiveness. So what drugs are more effective? So this is what this little chart is basically showing. And again, these are not exact figures. This is based on the best evidence. Some of the evidence is stronger than others. But by far the most effective anti-epilepsy drug is phenobarbital. Now, you may have some preconceived ideas about phenobarbital. It certainly does have adverse effects, but there is no doubt that it is the most effective anti-epilepsy drug for both humans and dogs. It doesn't necessarily mean it's the best choice for humans, but in third world countries, certainly phenobarbital will be used more than other drugs because it's cheap and it works. So always bear that in mind. Then we have bromide, imipitoin. So they're about as effective as each other, with less adverse effects. So that may be enough for that dog. We have zonisamide, but it is used as an add-on. Levetiracetam, which is an add-on, so you're adding it to another drug. And then just for context, and because if you do a lecture on epilepsy, you'll be guaranteed to get some comments. What about CBD oil? Or I've used CBD oil in my pet and everything is great. This is the effectiveness of CBD oil, and this was an add-on. So in addition to other anti-epilepsy drugs, at 9 milligrams per kilogram twice daily, which will have an impact on the liver because CBD, cannabinoid, requires to be metabolized through the liver. It's actually quite a complex molecule. So you will need to monitor liver parameters if you were to give this drug. And yes, it is a drug. It may come from a plant, but it's still a drug. I say I only put that in for context, not because I recommend it. Because CBD oil is also very, very expensive. And in case somebody's wondering what 9 milligrams per kilogram looks like, that's about a bottle's worth in one go for many preparations. So what does the literature say? Well, phenobarbital, there's very good evidence, as I've said before, that given as a monotherapy, meaning giving as one only drug, that it will be effective in a good proportion of cases. With imipetone, there's good evidence that it's useful as a monotherapy, not as effective, at least in my experience, as phenobarbital. But it's certainly, I find, a useful drug in some instances. But there's insufficient evidence that it's useful as an add-on therapy, but it is occasionally used. With potassium bromide, there's fair evidence that it's useful as a monotherapy. And surprisingly, this was a shock to me, there's insufficient good evidence that it's useful as an adjunct therapy, but I would tell you anecdotally it is useful as an adjunct therapy. It's really commonly used, and it's what most neurologists go to would be a combination of phenobarbital and bromide in a more difficult to manage epileptic patient. For levetiracetam, there's fair evidence that it's useful as an add-on therapy, although it's debatable whether or not this is long-lasting, and we often talk about the honeymoon effect. You're having a good effect initially and not so good later on. And zonisamide, there's insufficient evidence. It's often used as a third-line agent in the UK, however, and in the USA, where it's considerably more expensive, some people will use this as a first-line therapy. But of course, we're talking about patients that are being managed on a budget. And then after that, we have all the other anti-epilepsy drugs that you may have heard of, and of course, CBD oil if you want to go there. So, where does that leave us? When we're choosing the medication, we have to consider the cost, we have to consider whether it's effective, and then finally we have to consider our adverse effects. And this, it comes down to the drug, the dose of the drug, and the combination. And that's very important, it's the combination. So I often will get called by a veterinary surgeon wanting advice, saying, well, we started the dog on phenobarbital, we increased the dose of phenobarbital to X, and then we added bromide, and now the dog is really sedated on the bromide, so we've taken away the bromide. What do we do now? Well, the dog was sedated on a combination of the bromide and the phenobarbital, not necessarily the bromide itself. And the easier thing to do, because the high dose of phenobarbital wasn't working, would be to use that combination of phenobarbital and bromide, but reduce the dose of phenobarbital. It's about achieving a balance. So what are our adverse effects? Well, with Pexia and imipetone, its advantages are its very short half-life, and it achieves steady state in 3 days. That means that 3 days after you've started to give the tablets, it will be steady in the dog's system or the cat. It can be used off licensing cats, and therefore it should be working within 3 days. It is a targeted action, so it binds when GABA is present at the synapse. So it's a little bit like saying that it's a light switch that you can switch on when it's needed, rather than a light switch being on all the time. You don't have to do therapeutic monitoring for it, so that those costs associated with blood testing and monitoring are not applicable. There's less adverse effects of sedation. It's metabolized through the liver, but it's not known to actually cause damage to the liver and cause cirrhosis. There's less PUPD, or drinking more and urinating more, and there's less stimulation of the appetite, and it also has an anti-anxiety effect, which can be useful in epilepsy, because epilepsy is a global brain disease, and many animals with epilepsy will also have other emotional health problems like anxiety. Its disadvantage is it's meant to, at least in the trials, cause more hyperactivity, adverse effect than phenobarbital. That's not a guarantee, but both of those drugs can potentially cause that. It was meant to be a higher percentage in imipetone. I have to say I've never seen that. Phenobarbital is actually a more effective anti-epilepsy drug, as I've said before. So if you've got a dog on phenobarbital and it's stable, I would say stay on it. However, I routinely use imipitoan for dogs with single seizures that are more than 2 weeks apart, and a good proportion of dogs will stabilize on that drug. But as I said before, out of the 3 drugs, it is the more expensive. Phenobarbital, many different agents for that. I'm not promoting any particular drug. The pictures are there because it makes it prettier. So its advantage is it controls epilepsy in about 50% of patients, and about 33%, another third, are improved. That's a good 80%. But that does suggest that up to 30% of the patients are poorly controlled. It definitely, out of all of the drugs, there's more initial sedation with phenobarbital, which can really put some people off. You really have to use your skills of persuasion with some caregivers and explain that this is a temporary adverse effect because their dog will look like, or cat will look like it's drunk. Causes more PUPD, increased drinking and urination, increases the appetite, and many dogs as a result will eat more or get fed more because they're more demanding of food and will gain weight. It does have to be given twice daily. It is metabolized by the liver, and occasionally and rarely you can see idiosyncratic adverse effects such as behavioral changes, and it can potentially damage production of white blood cells. So you can see pancytopenia or neutropenia, and it's important to monitor for that, for those rare cases that will come down with that. Very rare. I mean, we're talking way, way less than 1%. Potassium bromide, its advantage is it's once daily, it can be added to phenobarbital, and it's not metabolized by the liver, so it's one of the only liver-safe drug. Its disadvantage is that it is a gastrointestinal irritant. It should be given with food, and it can take 4 to 6 months to achieve a stable blood concentration. It's also affected by dietary salt, which means if your dog has a very salty treat, you have to have a very, very salty treat, like a lot of salt. I'm talking like drinking seawater. Then it can pee out its bromide. Likewise, if you change the diet to a low salt diet, so for example, if you decided to do some home cooking and went from a cheaper dog food which contains a lot of salt to, say, home cooking where you added no salt, then the bromide level that was previously at a reasonable level in your dog's blood could suddenly shoot up. So you need to be aware dietary change can affect this drug. It can also cause sedation as a thought of an increased risk of pancreatitis because of bromide affecting the chloride channels in the pancreas. And at high doses, it can cause neurological or neuromuscular issues such as proprioceptive deficits and megaesophagus. Let's deal with that elephant in the room, the hepatotoxicity. Phenobarbital, phenytoin, primidone, and zonisamide, especially combinations of all of those, will increase the risk of liver failure. Your aim is to measure the blood concentration of those drugs. I mean, really, nobody uses phenytoin or primidone anymore, but I put that in there because historically, people used to add those to phenobarbital, and that they were asking for trouble. So you need to measure the serum concentrations and maintain within the therapeutic range. And personally, I avoid dosing phenobarbital more than 6 milligrams per kilogram twice daily or 12 milligrams per kilogram per day. There are some that don't agree with me, but I'm quite long in the tooth. I've been managing epileptic dogs for over 30 years, and so I have seen some dogs have problems later on in life because I've been managing them for over, or they've been on this, not I've necessarily been managing them, I've seen them on this dose of drug for years. So what somebody with less experience will think the dog is coping with because they've been okay for a couple of years, I might have seen them 10 years later when their liver is not coping. So that's just me and my recommendations. I do liver function tests every 6 to 12 months. I would prompt you again to say that liver enzymes, elevated liver enzymes, do not mean liver failure. We expect the liver enzymes to be high when you're giving a drug which is metabolized by the liver, because it induces those liver. So the ones that you need to monitor for function are bile acids and albumin, and hypoalbuminemia, in my experience, and as I said before, I'm a bit long in the tooth here, is the first thing that happens when the liver is having problems with these drugs. I've bombarded you with information here. It's really information overload. And so we need to make some conclusions here. So these conclusions for the caregiver with financial constraints is, first of all, is epilepsy management fair or the right option for this dog or caregiver? If they're out on the street, then maybe it's just not the right option. Phenobarbital is the cheapest drug and is the most likely to work, but it does require monitoring. So you do need to have that caregiver come in and have that drug monitored. And you also have a prescribing responsibility. Is it going to be stored safely? Bromide is an alternative. It's an add-on for severe cases, or for those that struggle with facilitating twice daily medication, and it requires less monitoring. Imipitoum may work out for some caregiver budgets. It has less adverse effects and no cost of monitoring, and you may be able to reduce the cost for that caregiver by using an online pharmacy. We also have to manage clients' expectations. There's no doubt epilepsy is extremely distressing disease, and many clients are still trying to get their head around the fact that the animal has seizures, especially if they've never seen a seizure before, let alone get their head around the fact that they have to give medication to their previously what they thought was a healthy pet. It's a lifetime commitment to that animal. Giving regular medication is challenging. You know, people have social lives. They need to go out in the evenings. That's very difficult for them to be back in time to give medication at X time. And some caregivers find attending veterinary consultations for monitoring and repeat prescriptions completely challenging. And so there does have to be a discussion about what is actually practical for that caregiver. And remember that although very upsetting, euthanasia may be the best option. Otherwise, I do hope this lecture has given some helpful pointers to those caregivers with an epileptic pet on a budget, and help provide a way forward there. What's coming up soon when this series of lectures on epilepsy? Well, I hope to discuss the management of status epilepticus in general practice, giving some practical tips with that. And I also plan to answer those questions about diet and vaccines, yes, tentatively going into that area, objectively, without bias, and looking at the evidence. Thank you very much.